I am honored for two reasons. Number one, the scientific committee of the AIOS has given me this opportunity to conduct this instruction course. And number two, this morning I am seeing a full house, so I really feel honored. Dr. Devendra was talking about the functional test, and I will take you one step forward and would be talking upon the role of imaging in diagnosing glaucoma. And not only the diagnosing glaucoma, but assessing the progression as well. Are these imaging technology are really helpful, or they are just the colorful pictures by virtue of which you can impress the patients and their relatives? That is a very, very important and a pertaining question. But let me tell you that yes, I do not deny that the perimetry is of paramount importance, and without perimetry we cannot diagnose the glaucoma. But still the perimetry has its own problems. If the patient is debilitated, patient is old, patient is illiterate, patient has a Parkinsonism, patient has a severe dry eye, cannot perform the perimetry well. In my practice, when the patient does the perimetry for the first time, almost the 30% of patients are not able to perform the perimetry well. So what is the answer? What is the solution? Obviously, we do not want a good subjective test. Rather, we are looking for an objective test where we are not dependent upon the response of the patients and obviously not upon the technician who is performing the perimetry. Rather, it is the patient who just sits in front of the machine for a couple of minutes and the printout is out, the result is out, and you know whether the patient has structural damage or not. Obviously, we are looking for a machine which can have a high sensitivity and the specificity, and which can not only diagnose the glaucoma but can assess the progression of the glaucoma. Somehow, all the perimeter have not evolved to that extent, but I don't know, with the SRAP source, OCT and all, maybe 3 years or 5 years down the line, OCT may become the gold standard in diagnosing the glaucoma. What all we look to diagnose the glaucoma? You just look at this picture. We assess the optic nerve head. We see the cup in the center. We look at the neuroretinal rim. We look at the RNFL, and we look at the macular area. And all these things can be assessed by the perimeter. What the perimeter does, it identifies the center of the disc. There is a good registration through all these vessels, the retinal vessels, and it assesses the RNFL at around 3.5 or 3.46 millimeter diameter area. This is of paramount importance. Obviously, it does assesses the optic nerve head, the cup volume, the vertical and the horizontal CD ratio, the neuroretinal rim area, and also it does assesses the 6 millimeter tube around the optic nerve head to give a good assessment of the RNFL or the retinal nerve fiber layer. The TSNIT, the temporal superior inferior nasal temporal, is the very important in OCT. And what is the TSNIT? This is the diameter around the cup. As I said that it is somewhere around 3.46 millimeter. This is cut open from here and spreaded horizontally, and it makes the TSNIT curve. What green you are seeing here is the normal, the 95 percentile of the normal. What yellow you are seeing here is the 5 percentile of the normal, and red is the 2 percentile of the normal. If anything falls in the red zone, obviously that is abnormal, and the black line represents the RNFL thickness of the patients. How to read the printout of the OCT? This is the printout. Here what you are seeing is the RNFL thickness map. The darker is the color, more thicker is the RNFL. And here is the deviation map, which probably you can say like a pattern deviation plot in the perimeter. Here, whatsoever the red and the yellow you are seeing is the area of the RNFL loss. Here again you are seeing the stress-knit curve. Here is the RNFL value in the 4 quadrant, and here is the RNFL value at each clock hour. Apart from that, what you see over here is the the disc area, the CD ratio, the neuroretinal rim volume, the cup volume, the vertical and the horizontal CD ratio. So all these values you get as a ready-made. You don't have to do lots of hard work. And as I said, that the third important thing is the ganglion cell complex, because 50% of the neuronal cells are the ganglion cells, which get lost in the patients having a glaucoma, are concentrated in the macular area. So that area is of a paramount importance, and some of the OCT machine is capable of scanning this area. They scan the 7 millimeter square region in the macular area. And again, you get the thickness map and you get the significance map over here. And that is what the printout is. In the printout, you get the optic nerve head, the cup, the RNFL. Sorry, this pointer is not working. Can I have another pointer? Thank you. So this is the disc, cup, RNFL, and this is the macular map, right and the left eye. And here is the thickness map, and here what you see is the deviation map. The brighter is the red is the color, there is a more deviation from the normal. And you can do the progression analysis as well on the basis of the GCC. And you can do the progression analysis. Again, it's a ready-made software available in most of the machine, where all the OCT done over a period of time is analyzed, and here what you get is the average RNFL thickness, here is the superior, and here is the inferior RNFL thickness. And what you see is the likely damage, and here is the likely progression, and here is the probable damage. So all these are available ready-made. I am honored to have Dr. GC. Can I request Dr. GC to come on the front seat, because Dr. GC is a guru and a mentor of mine. So this is the third point, I am honored to have Dr. GC over here. Dr. GC, please come forward. And if you can come on the dais, I will be honored. So that is, sir, please, on the front row. So that is what we have presented in one of the World Glaucoma meeting in Boston way back about 6 years before, and that is what Professor Weinreb and their group have published in the year 2012. And you can see on the RNFL thickness map as well, and the deviation map, that how there is a progression in the RNFL. So you can assess the progression. It's the ready-made software is available. How reliable it is, that is $1 million question. But yes, it's an easy way to go out, and it's the structural assessment. It's based on the structural damage assessment. Just a couple of examples. You see here, this patient has almost the normal visual field in both the eyes, but on the clinical examination, the discs were looking very suspicious, and when we did the OCT, you can see that the whole papillary macular bundle is lost, and you can see that the enlarged cup, significantly enlarged cup. The another example, number of times we have done the perimetry, and this is what the perimetry results are. We were not very sure. This eye was looking like a superior arcuate biarcuate scotoma, and with a split fixation. And when we did, we were sure on clinical examination that this patient cannot have so much of damage, and when we did the OCT, there was hardly any RNFL damage or glaucomatous defect. That is again another patient of the same kind, and you can see that a pretty healthy RNFL. Look at another patient, this young one-eyed lady, and I have done the follow-up for this lady for almost 7 years, and she had a strong family history of glaucoma. When she came to me, only at 7 o'clock hour, there was a RNFL loss, but all the time, the standard automatic perimetry was normal, and 3 years later, you can see that the same area, it has progressed. So obviously, on the perimetry, again, it remains the normal. So based on the OCT, yes, sometime you would be able to pick up the progression in glaucoma. And look at here, that is what we have done the study, the aggressive lowering of the IOP by trabeculectomy, and you can see that there is a thickening in the RNFL. And again, of the same patient, you can see the volume of the cup before surgery, and it is 6 months later following the surgery. The volume of the cup has significantly reduced. It is an acquired pit, that is what you can document. Look at this, what is wrong with this picture? The patients underwent the OCT, this picture is there, and 10 minutes later, because I know, I did the applanation tonometry, the Goldman applanation tonometry, the patient underwent the perimetry, the patient's eye became dry, lots of SPK, was not able to, we are not able to capture the good images. We put the lubricating drops 3-4 times, and then after that on the same day, this is the RNFL thickness map. Look at this. The perimetry is not always right. Look at this. A large CD ratio. A large CD ratio. Look at this. This is the the optic nerve head of a patient, the right and the left eye. And look at this. Again, all 5 OCTs machine which are available, everyone says that it has a horizontal 0.9 almost, and vertical is also significantly large, because how it identifies the margin of the disc, it is important. It's the termination of the Brooks membrane, or the choroid, or the RPE, and also the attachment of the vitreous base affect in the identification of the disc margin. And because of that, the disc margin is not identified well, and that's why the CD ratio is pretty high. This is my own disc, and I have done my OCT by all imaging technology. Look at this. This is just a blink effect. Look at this. The patient has just moved the eye, so because of this you are seeing the deviation in the vessel, and that's why you are seeing a big hump over here. Look at this. This patient has a disc hemorrhage, it's a splinter hemorrhage, the RNFL defect, but the OCT says that everything is normal. OCT cannot pick up all these things. OCT cannot pick up all this kind of disc. This is all very, very difficult to image even by this. You have to depend on your clinical judgment and the acumen. There is an inter-test variability, 5 minutes apart. This test has been done, and this is all green, and you can see that there is a deviation. This is in a total optic atrophy. The patient has a no PL. So the glial tissue can be picked up as a RNFL. That you have to keep in your mind. You can see that there are lots of healthy looking nerve fiber bundle, but it is not the healthy looking nerve fiber. This is just the glial tissue picked up as a RNFL. In the young subject, yes, less than 18 years of age, we do not have the normative database. So yes, the OCT is a technology which is evolving, maybe 3 years or 5 years down the line. It may be very useful to us. As on today, yes, it does give us some information, but probably we have to more rely upon our clinical judgment, assessment, and the standard automated perimetry still remains the gold standard. Thank you very much.